Okay, I think that's everyone thus far. I think others may come and go. So thanks for joining us. I'm Simon Leigh. I'm the health economist and head of research at ORCHA. And apologies. It's my job basically to help people get their technologies evidenced ultimately and prove that their technologies do what they say on the tin, basically, to put it in layman's terms. All about evidence, all about corroboration and backing things up, so that ultimately when you get to the point of procurement and trying to get these technologies into the NHS or into other healthcare organisations, you have the background information and the real world evidence to assuage any concerns from potential clients and commissioners that your app is going to do, or your technology is going to do as intended, and that ultimately it's going to deliver a benefit that is worth paying for. And that's the whole theme of today. It's looking at what is the opportunity with digital health, where is it heading, is it growing, and how has COVID affected this opportunity, and then looking at, if you are to embark on this journey, which I'm sure many of you are, given the subject of the webinar, how you best go about obtaining this evidence and the hurdles that you may have to overcome in order to get over the line and to the enviable position where your technology is being used in the real world by people with unmet needs. And so what we're going to do is we're going to do questions at the end, just purely because from previous experience this tends to work better. So if you could hold any questions and jot them down, and we will do them at the end, right at the end of the presentation, which will be in about 35-40 minutes time. So I'm going to jump on and get cracking. So first question is, are healthcare apps and mobile healthcare the future? For me, unequivocally, I'd say that there's a very good opportunity here. No, by no means health apps and mobile health, it's not a silver bullet. There are a lot of amazing technologies out there, but there are a lot that are absolutely terrible as well at the same time. So, unlike pharma, unlike traditional med tech, where everything has to get over a certain line, a certain accreditation line, has to be regulated, and you're only going to get it, in your hands if it's of a certain quality. Obviously, that's not the case with mHealth. You can have quite literally anything from the most evidence-backed tool all the way to something which has no evidence whatsoever. Sorry, 1 second. Oh, there we go. Just checking. And it could potentially be an illegal medical device. So there's quite a spectrum of things that you get with mHealth. At the moment, there are about 366,000 health and fitness apps on the two major app stores, so on iOS and Android, and there's about 5 million downloads of these every day. So massive opportunity for downloads if you can get to the front of that queue and you can be seen as an app that's high quality, that has high reviews, that's ORCHA accredited, that's within NHS hands. But it's also really hard to get that visibility. 366,000 apps to fight against. Quite difficult to jostle yourself to the top of that queue and to differentiate yourself from the rest and ultimately separate the wheat in these apps from the chaff, which is the majority. And that's something where ORCHA can hopefully help you hold your hand along that process and make that a lot easier. So just as a background in terms of which apps are available to date, just in case your mHealth solution falls into any of these categories, there are about 50 million downloads of weight loss apps every day worldwide, about 26.5 million of exercise apps. That's everything from Pilates to to Fitbit, right the way up there. Women's health apps, 10.5 million downloads every day. Stress and meditation, 8 million. Pregnancy apps, 7.5 million. Obviously, this is cyclical, so it's constantly refreshing demand. And tools and instruments. So things for diagnosing, checking general health, keeping abreast of day-to-day health parameters, 26.5 million. It's the same as exercise apps. So there is a huge demand for these technologies out there, and it's our hope that we can fill that demand with high quality and ultimately evidence-based tools that do ultimately provide a benefit. Now, obviously, I'm quite biased. There's no two ways about it. I work for an organisation that truly believes in mHealth and believes in digital health, but it's not just about what I think. We've done surveys with healthcare professionals in the past. We've done quite a lot of these. You may have seen these across our various LinkedIn, Twitter, and other social media feeds where we've asked for professional opinions. And what we've seen is that approximately 80% of healthcare professionals are now using smartphones and medical apps in some way or other with their patients, whether that's them using technologies that are on their phones and their laptops, any smart rectangle that they have, or whether that's them actively recommending these technologies to patients and giving them a link or the name of an app to download. We know that about 40% believe health technologies can reduce the number of visits to doctors' offices. Obviously, we've seen this with COVID at the moment. Technologies can fill some of that void and take up some of that excess demand, which doesn't always need to be face-to-face. And we've seen that 93% believe that these apps can ultimately benefit and improve patients' health, which obviously is quite a striking number, 93%. That's quite a significant amount from the surveys that we've seen. So if people are using these technologies, if they believe that they can reduce visits to doctors' offices where not necessary, and if they believe that ultimately these can do good, there's clearly a primed market there ready to use these technologies, provided that you can get one that is evidence-based, safe, clinically efficacious, and that healthcare providers don't perceive as a potential risk, because obviously ultimately, first do no harm. We need to make sure that what we do offer is safe and effective. Now, in terms of the apps that ORCHA have reviewed today, obviously ORCHA spend all day, every day, Monday to Friday, reviewing these digital technologies, and we've reviewed thousands today. You can go and see this on the ORCHA website, appfinder.orcha. And what we've seen is that over time, there has been a dramatic decrease in apps that we call general lifestyle apps. So that's diet and nutrition, lifestyle and stress, exercise and fitness, these overarching general wellness apps that that provide general background information on living a healthier and better life. But as these have gone down from 2017 to 2020, we've seen a corresponding increase in the number of apps that are in very specific conditions, disease specific, women's health and pregnancy, these niche areas, and even rare diseases. We start to see these pop out in, and that's just because over time, as the number of health apps has grown, naturally, if there's an unmet demand, it's filled by a technology over time. We're starting to see this growth and this spread of information and technologies into the farther reaches of condition management. So it's not all just your Fitbits and your calorie counters. We're looking more at more specific, user specific advice and guidance and ultimately help here. In terms of condition specific apps, unequivocally, the majority at the moment are mental health related. Just over 1 in 4 are to do with mental health, various facets, whether that's OCD, whether that's anxiety, depression, stress. It takes up a lot of our review time, and there are a lot of technologies here and a lot that are very good. Diabetes also 1 in 6, heart and circulatory 1 in 9. Generally, the number of apps available kind of correlates to the prevalence of disease in the real world. So the higher the incidence and prevalence, the higher the number of technologies for this, usually because the more people that have suffered from it or know someone who's suffered from it and want to do something about it. So we can see these increases here, but generally, almost half of all health apps that we see are either mental health, diabetes, or heart and circulatory. So, but still we're seeing growth in places like fibromyalgia and CME, in pain, digestive system, IBD, IBS, Crohn's colitis. We're seeing growths there. So there's clearly a market for these, and they're receiving funding left, right, and centre, and accreditation from groups that we work with to help get these technologies evidenced and over the line. Now, obviously, we're not blindly going into this saying that health apps are amazing and that they're really easy to get into the hands of patients. We know that it's an uphill struggle to get good technologies into the hands of patients via their healthcare providers. And the reasons for this, we think, are fourfold, and this is from our observations over the past 4 or 5 years. Awareness is still very low of digital health, even with COVID. COVID has been awful for almost everything, but it has been good for one thing, and that's digital awareness, digital advocacy, and digital literacy. People have been forced to use these technologies who previously didn't want to, or whose healthcare providers previously would not recommend these technologies out of necessity because this was the only option. It was either this or nothing. And despite that increase from COVID, there are still a lot of healthcare providers and a lot of patients who aren't aware of the variety of apps, the variety of platforms that can be used for day-to-day conditions that are evidence-based. A lot of this comes down to medical education as well. You know, there's still no guarantee within medical education pathways for up and coming and junior doctors that digital health is a part of that. You'll learn about first aid, emergency care, you do your rotations and your SAMPs, but ultimately nothing about digital health as yet. And there's still a lot of work to go there. The second thing is accessibility. Obviously, 366,000 apps, that's a nightmare. Like if you're looking for a holiday, you'd want to use something like, you know, Travel Supermarket and find things that you really want as a patient or as a healthcare provider, things that your patients really need so that you can recommend the right technologies. And because there's so many, it's really difficult to find the right technologies a lot of the time. If I'm a you know, a cardiac surgeon, I want to recommend an app to somebody to brief them on what's going to be happening to them over the next few weeks, pre and post surgery. You can imagine trying to find that app in the App Store. It's quite difficult, and you get thousands and thousands, and then when you do see them, you wouldn't know which one to trust. And that's ultimately our third point. So, you know, this lack of suitable quality indicators ultimately for health apps that stops people ultimately, you know, embracing and taking on these technologies, because there's that lingering doubt as to whether these apps ultimately do as they should, and that they're not unsafe, either from a data perspective and losing either sensitive or personal data, or from a clinical perspective in recommending the wrong or a potentially dangerous course of action. So great example, type 1 diabetes, insulin adjustment apps. I'm a type 1 diabetic, and I've seen some insulin adjustment apps that are pretty shocking, that are not evidence-based whatsoever. And if I have 10 grams of carbs and I accidentally put 100 grams into my machine, it doesn't flag that up, I'm going to be taking 10 times the amount of insulin I should. So it's little things like that. So trust is still a big deal here. And finally, governance, the lack of clarity around the regulatory landscape. It's really important to recognize that apps are not like pharmaceutical products. They are not medicinal products. If you leave a tablet in a cupboard for 6 months or even 12 months, as long as it doesn't go past the expiry, that tablet is going to do exactly the same thing 6 months later as it does today. But with a health app, updates come by every day, things can change, data privacy policies can change, the back-end infrastructure, algorithms can change daily. So if you review an app once one day, it may not necessarily be the same app a year down the line. It may not even be the same app 2 days later. So there needs to be something in place that can basically keep up with the speed of updates and the speed of development for these technologies. And that's something where ORCHA tried to come in, and we do try to review every app as soon as it is updated, so that we can stay on top of this, and ultimately so that end consumers know what they're dealing with. Now, the way that we do this at ORCHA is, you may have heard of the ORCHA baseline review. We have a roughly 300-point questionnaire. It's going up all the time. This is 260 here, going up constantly as we subsume more and more guidelines from around the world. And basically, it's an MOT for apps. We take an app, we get our reviewers to look at it, and they pull it apart from security to data privacy to user experience, clinical assurance, clinical safety. And we try and really get under the skin of what these apps are doing, and ultimately whether they're posing a risk or a benefit to end users. And when we've done all this, we create a score. You know, basically, the score gives you an assessment. It's normalized from 0 to 100. If you have a score of 100, you adhere without exception to all best practice guidelines that are recommended for mHealth technologies across the various domains. If you have a score of 0, you're likely to be a serious risk to users' health or an illegal medical device, in which case we would not recommend. We also supplement this with what we call enhanced reviews. We have a team of clinicians that work within ORCHA, specialists in everything from diabetes to midwifery, heart health, you name it, they're all there. And they'll basically take more detailed assessments of these apps, where they'll look at the data, check that the clinical outcomes are relevant within that therapeutic area, or are they a straw man? Are they using the right outcomes that align with ultimately national outcomes frameworks? We want to know that these apps are ultimately of value. But then obviously we accredit at ORCHA. So, you know, we can, once we've done our reviews and we're happy that these apps are safe and or effective, ideally both, we will then provide an ORCHA stamp and accreditations so that this is visible to external partners. And the general rule in the NHS that we've seen at the moment is that, you know, if you can get an ORCHA stamp, which is generally you have to have a score of 65 or over, that's an outward signal of quality. And it's the one signal quality that has remained consistent over the past 4 years. We've seen changes with NHSX, with NHS Digital, with PHE, with NICE and the ESF, and all these various different accrediting bodies that come and go and try and reinvent the wheel. But the one thing that has stayed constant over that time, and this is what we've received feedback on Twitter, is ORCHA. It hasn't changed. It's only grown and added more questions, but the review has stayed the same all the way through. So, and this is now an outgoing signal to a number of our NHS partners. Now, obviously, if you get your app reviewed and we work with you to develop this and to get it to a point where we believe it's safe and it's valuable, it can really make a difference or fulfill an unmet need, it will go in an ORCHA library. It will be promoted in these libraries, white labeled libraries for our various clients. The one in the big laptop there is one that we did for Salford Royal, and there are a few others. And basically they're just made visible so that anyone who's looking, that clinician that wants the app that's about type 1 diabetes and insulin adjustment, they can find one that they know has been assessed and is first going to do no harm. And they can find it a lot easier than going to Google and looking through 366,000 of these. Now, obviously we touched on this a little bit before about COVID. You know, have digital health apps help with COVID? And we believe unequivocally, and I certainly do, that apps and health platforms, digital health in general, have certainly been of significant benefit within the COVID-19 landscape. If you imagine that most people, routine appointments, scheduled appointments, you know, all these things that we do in order to maintain our health, these have been exceptionally hard to come by over the past few months. We've really struggled to do our basic self-care. And if you're unable to see your doctor face to face, like a lot of people are, particularly if you're rural, if you're out of the way, or if you have other issues that prevent you from taking appointments when they're offered, they've been there for everyone just to help them from home. And we've seen significant increases in use over this period. ORCHA are constantly watching to see what is being downloaded within our sites and what is being recommended by healthcare providers. And we've seen about 180% increase in sessions on our website. So that's long-term use. We've seen a 66% increase in page views, a 6,500% increase in recommendations from healthcare providers. So this is healthcare providers who use ORCHA to then recommend safe and accredited health apps to their patients. So that's gone up 6,500% over this period, and downloads have increased by 182.5%. Now, the difference between those two tells you that obviously not every recommendation ends up in a download, but this is obviously pooled data, and obviously there are some apps that tend to do a hell of a lot better than others in different areas, and this is something that we're working on over time, so that ultimately we can get the download rates for everybody increased, working with patients so they can work out what they need. And this is a new key part of ORCHA's review going forward, where we're looking at patient centricity to make sure that what is provided is ultimately a benefit to patients at the end of the day who are going to need it, and that it genuinely fulfills an unmet need and is going to assist with day-to-day living. Now, ORCHA are working with London Procurement Partnerships at the moment. We started this, it's been 2019, September 2019. And the idea with this is that we can help technologies that meet the relevant criteria and that are safe and effective to be procured within the NHS. And we started with the LPP because this is a routine, and this is dynamic. So this is constantly changing. It's not just we have the same vendors there who are constantly going out for if we need an app for circulatory health, or if we need an app for COPD. If you fit the criteria, you can get in there, and then if you are the best app needed for the requirements at that time, you are used. At the moment, the last time this was surveyed, there were about 1,000 that were in there at the moment, but roughly adding in about 100 every month, and that's going up and up and up. So this is kind of like a subsection of ORCHA where we, that the best of the best are going in here to ultimately be procured in the NHS. Now, before we move on to the slightly more quantitative and empirical side of this, and moving away from the background of digital health, ultimately at ORCHA we think there are 5 steps to truly unlock this power of digital health, and the power that we've seen through COVID, where people have been increasing their use. And for us, it's really simple. It's a proven approval that is driven by national policy. So that's having a very clear framework going forward of what is acceptable, what isn't, what makes a good health app, what doesn't. Obviously, we've seen recently a lot of changes with the various regulatory bodies. We saw the DTAC come out yesterday from NHS. This is changing quite a lot, and we're hoping that over time, when this starts to cement and calm down, it'll be much clearer to developers exactly what is needed. Getting these apps out to populations, obviously this is really difficult because, you know, it's not like we just have a list of patients with unmet needs on our phones that we can just ping a link to. We need to be able to work with healthcare providers here, and that's something that ORCHA do quite well. We're constantly working with healthcare providers in various clinical areas who express a desire to use digital health, and then ultimately who have the patients under treater care, who can then use these services. And we're always looking for studies to back up the quality of these technologies and to ultimately show that they have an effect in the real world. We need to be able to embed these solutions into care. So that's not just trying to fit a solution in and then work everything around it. We want the solutions to ultimately fit into an existing problem. They need to be able to slot into care pathways. Great examples include apps that we've worked with recently in mental health that slot into IAPT care pathways, so that while patients are waiting to see a psychotherapist or a counsellor, they're receiving something in that 4-week waiting time, so that they're not getting worse in that period. It just slots in there naturally, and because it slots in there naturally, it tends to work better and the outcomes are generally improved, because we're not trying to force something where it may not belong ultimately. And finally, economic sustainability via procurement, and obviously we'll touch on this considerably more now on the subsequent slides, but we need to be able to show that what we're offering is ultimately a value. We don't want to recommend a digital health product if it costs £200 per user, but if we know that the absolute maximum benefit we're probably going to get out of it is about 150. You know, we need to be able to evidence the health economic impact of using these technologies, rather than assuming that they will have a positive economic benefit, because we need to, like with pharma, we need to hit that holy trinity of, we need to be able to show, firstly, that these technologies have a benefit to patients, secondly, that the benefit is relevant and that it's something that we actually want to make a difference with, and thirdly, that intervening here then doesn't take away from opportunities elsewhere, so they need to be cost effective. And if we can get all three together, then we can prove almost unequivocally that diverting, you know, scarce NHS resources into your digital health product is the right thing to do, and that ultimately it generates more health than it takes away. So i.e., what could that money have done elsewhere? If we'd have put it into COVID vaccination, if we'd have put it into building a new baby unit, we need to be able to prove that ultimately this is cost effective. Otherwise, procurement is going to become exceptionally difficult, and it's obviously a massive hurdle anyway, procurement. But we need to be able to prove to procurement that this is worth doing, and this all comes down to evidence, which is handily where we're going to move to now. So my background, touched on briefly before, is I'm a health economist, so it's my job to generally look at existing care pathways, look at new interventions, whether digital or pharmaceutical, and then highlight where these technologies can improve outcomes or ultimately reduce costs, or if not both. And it's really critical to get both sides of this in kind of a cost consequence approach, because, you know, decisions are rarely one-dimensional. We need to be able to evidence that these technologies can make a difference, and that difference is ultimately worth having. People who develop these technologies generally have a real passion for these interventions. Someone who develops an app for COPD has a passion for reducing exacerbations. That's fantastic, but it's unlikely that people in procurement will have that same passion. So they deal in pounds and pence. So it's ultimately about bringing this back to the lowest common denominator, which is cash, and saying, yes, this is what our app does. This is the experience without it, and this is the experience with it, and showing the difference between the two. Now, obviously, there's lots of ways that you can demonstrate benefit within digital health. There's more than you can shake a stick at. Our preference is prospective. So, committing early on in your development pathway to embedding the right condition-specific measures in there. If you're working in depression and anxiety, make sure that you get a GAD-7 or a PHQ-9 in there, which then allows a direct comparison with the NHS standard of care, which is IAPT. If you're working in diabetes, make sure you get a HbA1c, a blood pressure, a weight, and a cholesterol in there. For COPD, it'll be an FEV1 and number of exacerbations. It's really critical that the prospective data is given serious consideration, because it is by far, once it's set up and you're past the teething pains of doing it, it is the most sustainable and cost-effective way of generating high quality evidence over the longer term. And this is where everyone wants to be at the moment: real world evidence driven by digital health. And this is something particularly where the pharmaceutical industry are looking to move, particularly given the the increase, the change in real world conditions. People are taking more concomitant medications than ever before. You're no longer just a diabetic patient or an asthmatic patient. You may be an asthmatic patient who's also diabetic, who's also overweight, who also has another immune condition. And getting that granularity from real world data unlocks so much more power about real world condition management. And the value of the data that you can collect through these technologies is immeasurable if you can better inform the natural history of disease. Now, retrospective data is obviously also exceptionally valuable, but not as much as prospective, purely because of the confounding issue. If you have collected data and you have got outcomes data, that's amazing, and that's something that ORCHA can help you analyse, and we can try and get to the bottom of this, and we can put you in contact with partners in the southwest of England who can run studies for you on this. And ultimately, we want to make sure that data that's been collected not only shows a benefit, but that it's taken account of all the potential confounders. So if you have got this data, we'd be looking for extra data in there that's important to your condition area. So for example, if it's a weight loss app, it'd be really good if we knew whether the patients were taking any other weight loss medications, for example, or whether they were under any other care for weight loss. Similarly, if it's within type 2 diabetes, it'd be great to know, okay, how long have these patients been diabetic? Are they more engaged because they're newly in their pathway where it's really a big deal? Or are they 2 years down the line where the shock of it's kind of worn off and they may be less urging and less willing to make a change? And all of these things make a really big difference to the value proposition, because they change the outcomes. And that's the thing, if we anchor on the outcomes, it's trying to explore everything that could have affected that outcome. With digital health, we have a fantastic opportunity to do that, because as long as we're collecting data that is relevant to the condition area as stipulated by GDPR, we're not just collecting data willy-nilly. We have a real strong case there for developing really high quality evidence. Now, obviously, we can do benchmarking as well, and this is exceptionally common, where we look at similar apps, we look within PubMed and Medline, we see what other apps have done, and then we make the case that our app is exceptionally similar to this app in terms of mode of action, in terms of the behavioural techniques used, in terms of the population under consideration, and we say this app did this, our app is exceptionally similar. We don't need to spend another 2 million on an RCT. We believe that we're going to be within a margin of error of this app, and that's that has historically been used. And the final one is testimony, relying on advocates and users to highlight the value. And this is exceptionally valuable from a why perspective, to say why things have happened. But from a what perspective, in terms of showing ultimately what happened, it's less so. And we'll go into this a little bit further on. That NICE, with their evidence standards framework, have made room for testimony as acceptable evidence, but only for certain types of app. If your app is something that diagnoses, that calculates, that provides ultimately the features of a medical device, and that ultimately has an inherent risk to it, user testimony isn't going to cut it in terms of evidence. If your app has a very low threshold for error and ultimately for patient harm, let's say it's a yoga app or something that recommends meal plans, testimony is more than likely to be acceptable, because the risks of getting it wrong, or having a biased sample, or someone giving testimony who maybe isn't being completely honest, are a lot lower. Now, we talked about NICE, but NICE have done an exceptional job in terms of trying to make this a little less of a Wild West and a little more of a, this is what you do, and in this order for health apps. Although we're not quite there, because we've still got lots of other people, DTAC and others, who are also providing guidance. It's a little unclear where they all fit in together and work together in an ecosystem. But in general, if you follow the NICE guidance, it will generally tell you what type of evidence you are going to require for an app with the functions and features of your technology, and similar for web portals. And NICE have broken this down into 3 tiers, which are really useful. So tier 1, the lowest inherent risk and the lowest evidence requirements are system services. So this is electronic patient records. This is the electronic version of the baby's red book, where you get your vaccinations and all of your important early years information. Moving on to tier 2, these are apps that inform, monitor, and communicate. So these may be basically journals, logs of condition, patient reported outcome measures that are within apps that provide generic information about a condition. So IBD, FODMAP diet, these are the things you should eat, these are the things that you should try to avoid, and then a list of, let's say, how many times you go to the toilet, presence of blood, etc. That would be a tier 2 app. And there's a moderate risk inherent to those. So as a result, the evidence requirements are pragmatic. And finally, there's tier 3, which is those that prevent, manage, treat, calculate, or diagnose. These are, these are at the upper end of the apps, and they're pushing medical devices. In many cases, they are medical devices. And ultimately, these are things that can ultimately lead to a change in condition management, which, if not evidenced and if not correct and not informed by best practice, can have serious, if not fatal, implications if used incorrectly. So back to the type 1 diabetes insulin adjustment app. If that calculation isn't spot on and I end up taking 10 times the amount of insulin that I should have, there's going to be implications for me when I get into the car to go and drive somewhere. These are things that can cause serious harm, and these are things that, as a result, are really put under the microscope. Now, here's probably a better way of showing this. This is how this actually looks, the evidence framework, and you can go away and get this from NICE. If you just put in NICE ESF in your in Google, you'll be able to download this. And basically, the requirements are there on the left. So your tier 1 apps, your patient health records, all they need is to be able to demonstrate a plausible mode of action that is viewed as useful by relevant professionals or expert groups. And that's your testimony. So that's going to somebody, if you're going to a midwife, for example, or a health visitor, if you've got the virtual red book, and saying, look, we realize that you do a lot of stuff in the community here. We could probably save you a lot of time. Would you like to try the virtual red book? They sign it off. You get a consensus that this is a good idea and that the information that you're collecting is relevant and equal to what's done in the normal paper version of the red book. That's going to get you through the ESF, more or less, and that's going to get you that tick. If you're a tier 2 app, you're going to need to be able to demonstrate that any health information provided is firstly valid, second that it's accurate, thirdly that it's up to date, and fourth that it has been reviewed by relevant experts. So back to the IBD app. If I've got my app for IBD that's tracking symptoms, stool frequency, and it's providing diet information, I want to know that that information about diet has been provided by someone who knows what they're talking about, and not just a child who's developing apps in his basement because he's exceptionally good with code. I want to know that this is a valid and relevant technology. So we'd be looking for some IBD specialists, some gastroenterologists, to put their name to this app and say, yes, I validated this information. I believe this to be correct as of this date. I believe that it's in line with current best practice guidelines as stipulated by NICE, the BSG, ECHO, for example, and I believe that this is going to do some good. And then finally, we move to the preventive behavior change, self-management, treating, monitoring, and calculating. That user testimony and that clinician willing to put their name on it simply isn't going to cut it. We need to know that without using this technology, outcomes X and Y occurred, and with using it, outcomes Z and A occurred. And we need to be able to take the difference and make sure that ultimately this technology doesn't lead to any harm and that it does lead to some benefit. And this is because these are going to be the technologies that ultimately change condition management. So they need to be under the microscope. And just like we do with pharmaceuticals for NICE, where we go through the technology assessment committees and we're slow and we evaluate the evidence and make sure that everything is correct, it's the same process with this. Unfortunately, it's a much slower, much more gradual and much more thorough appreciation of this technology to really understand what it does. There's just some tables here. We don't need to go through these too much. So if you've got to the point where after all of this, you think, you know what, I'm still looking to generate evidence here. I probably can't go in at the moment with a full-on prospective analysis, but I have some data and I want to start to put together a model to show how my technology may impact the local health service or how it may impact the health service nationally. Now, obviously, the first thing we recommend is that you have a look at what's already been done in your area. So go to PubMed, go to Medline, have a look at your condition area and start to find what's already been published, because Someone else may have already answered this question for you, which can help you further down this line, this procurement line and this development line. Ultimately, we need to be able to move you along the conveyor belt. And if somebody's already done some of the work, then why pay for it twice? So it's looking at what's already been published. Now, obviously, if you are looking to work within the UK, Public Health England have a treasure trove of data on natural disease, natural history, and of ultimately, real world condition management data. They have, absolutely tons, databases of mental health, diabetes, respiratory, heart health, everything. And this is by GP practice. So what you can do with this data is that you can start to have a look through and say, okay, I want to do a study here where I want to use my app, which is for depression and anxiety, and it's for those who are on waiting lists for IAPT. We believe that we can do some good so that people don't deteriorate when they're on a waiting list. What you can do is start to look at, okay, so where is the demand and where's the need highest? So we can go through to this slide and we can say, okay, where is the biggest wait for IAPT at the moment? Where are people waiting the longest in between seeing a GP and seeing a psychotherapist? And it's in the Wirral. It's 139 days from seeing the GP to getting into treatment. So I know that if I have an app that I want to use in the interim, that's where I want to start speaking to healthcare providers, and that's where I want to start planning my studies. I don't want to do it in Tyneside where I only have a 6-day window and I'm not going to be able to capture much data. Similarly, you can look at recovery rates and think, where is the unmet need the highest? Where are people suffering from the worst mental health at the moment? And you're looking at Scarborough. Scarborough have 5 people in every 100 who start treatment under IAPT reach a resolution, 1 in 20. In Greater Huddersfield, it's 51, it's 51%, so you may not want to go there. This data is exceptionally detailed if you can work your way around it, and there's multiple ways that you can pull this data in. You can API into this data, you can download it. So if you have a treatment that's looking at obesity and increasing levels of physical activity, you may want to do it somewhere like Barking and Dagenham, where the percentage of obese adults is one of the highest in the UK. It was 13th out of the 180 CCGs, I believe, that when this was pulled off, where excess weight in children is much higher, where the density of fast food outlets is higher. You're not going to want to do it in Bromley or Buckinghamshire, where they're all in the green. So, and it's just by using this data to plan your prospective evidence going forward. We see this with clinical trials all the time, problems with recruitment that slow things down. We want to make sure that wherever you do plan your future studies and you plan your engagement and getting clinical leads, involved, which is going to help you with procurement down the line, we want to make sure that you're doing it in a place where the need is greatest, so the opportunity for data to capture is ultimately the highest. Now, we recommend at the moment, and NICE with the ESF recommend a cost consequence approach to evaluating health apps and evaluating what benefits they have. And cost consequence is basically just a fancy way of saying, how does it impact economic outcomes and how does it impact any other clinical and or other outcomes? We want a holistic view of what this technology does. We're not just focusing on quality adjusted life years like we would tend to with pharma. We're focusing on any benefits where they can be evidenced, which is really handy for a health app and health, digital health developers, because it allows you to define your own outcomes here. As long as you're hitting the key clinical outcomes that ultimately the healthcare providers are going to care about, if you can collect data on some of these as well, you're going to have a much more persuasive offering when you come back to procurement. So if you can say, my technology is cost neutral, it doesn't add to your costs, but it doesn't take any costs away. It's roughly the same. There's a few pounds in it, but it does reduce waiting time significantly for those who are on IAPT waiting lists, or it reduces wastage, or it improves access and equity, or it reduces pain or improves quality of life. There's a whole plethora of outcomes that you can use. And NICE haven't been hard and fast on this. They've tried to keep this as open as possible. But as long as it's relevant, and you can evidence this by way of a study or by way of testimony, if your app is that type of app and it's a tier 1 or 2, then that's absolutely fine. And the way that we like this to be shown, and this is really basic, is basically what's going to happen if I use your app and what's going to happen if I don't. And this comes back to the example from before with the waitlist for IAPT, and this is from an actual client. We've had permission to use this. We looked at GAD7 reductions under IAPT in this area. The area was Cheshire, so we used the data from from Public Health England to find out, okay, on average in Cheshire, how long are people waiting for IAPT? What is their general GAD7 reduction? How long are they waiting overall? And what's the general cost of that treatment? And we saw that usually in that area of Cheshire, it would have cost £1,042 to go through from the point of seeing the GP to the point of leaving the service. It would have took 47 days to get into the first appointment, and a GAD7 reduction of 6.5 points out of 21 would have been experienced. Now, we collected data for the app and the digital technology side, and found that the cost was actually about £250 because people needed many fewer face-to-face appointments because they'd done a lot of the heavy lifting while they were on that waiting list. The average wait to get an app into their hand was just 1 day, and the GAD7 reduction was slightly higher. So when you look at it, the cost per GAD7 point reduction, you're paying £160.30 under the existing standard of care to get one GAD7 point reduced. So that's at 1 in 21 maximum points reduced. And with an app, it was £30. So it was 5 times more cost effective to use an app than it was to use the existing standard of care. And that's the level of analysis that's required and putting it into context. Now, you can change this and you can do examples in emergency care. So we mentioned I'm type 1 diabetic. And if you're newly diagnosed with type 1 diabetes, it can be quite a steep learning curve. And for months and months, you still have to get used to how to exercise, what to eat, when to eat. And there are many things that obviously affect your blood sugar if you're unwell, if you have viruses. So this was for a technology that provided support to newly diagnosed diabetics in the hope that it would reduce episodes of both hypo and hyperglycemia. The premise being that with both hypo and hyperglycemia, you can need to be admitted to hospital, and sometimes by ambulance if things go awfully. So we looked at basically what would happen if this app was able to reduce the likelihood of hypoglycemia and hyperglycemia by X percentage points. And you can see bottom right that basically as the cost of the app went up, the value of the app went down. As the reduction in hypoglycemia went up, the value of the app went up. So for an app that costs only £10 and reduced hypoglycemia by 50%, the NHS would have paid £24.30 per patient for that app. Whereas if it cost £20 and it only reduced it by 5%, it would have actually cost the NHS an extra £5.50 more than they're paying now. So that wouldn't have been acceptable. That's worse than cost neutral. And it's breaking it down in this way so that you can understand where you need to show benefit. So if I need to show benefit for a diabetes app in hypoglycemia, I know that my studies and my app need to make sure that they're collecting hypoglycemia data so that I can show unequivocally that use of my app reduced the likelihood of hypoglycemia compared to those that weren't using it. And it's getting those triggers, be able to find that, and that's really important for your data collection. Now, obviously, I wouldn't be doing my job as a health economist if I didn't talk about sensitivity and robustness. You need to be able to make sure that the data that you collect, that you are very honest about it, about how it's been collected. So what if the clinicians who were recommending or delivering the service weren't representative of those in the real world? What if my study showed that 50% of patients would be recommended the app because the healthcare providers that I have in my study were digitally engaged and were really bought into the study? What if in the real world it was only 10%? Would that reduce the reach of my app 5-fold? And would that ultimately have an impact on the outcomes? Would it still be cost effective if we were paying at the population level rather than at a license level? And what if the patients that we included were self-selected and were most likely to succeed? So coming back to the type 2 diabetes example, what if I only used patients who were newly diagnosed and were really keyed up and really wanted to make a difference because this was seen as a really big deal? But what if after 2 years, and you're giving this to somebody who's had type 2 diabetes for a while, they may be less interested because they've got used to managing the condition? And ultimately, what if we over or underestimate the cost of existing care? So if we go back to our previous example before, what if the app while waiting actually cost twice as much because it didn't reduce the number of follow-on appointments by as much as we thought it did? What if you had to wait 3 days for it instead of 1 day because of teething problems and because of people getting hold of links? What if the GAD7 reduction went down a little bit? And these all play into our decision making. We need to work out if after we make these changes, is the outcome, the ultimate, this is cost effective, this is effective, this isn't, is this going to change? And it's really important that we work out the parameters that make that difference, because that's where we want to focus our evidence going forward. If my technology for diabetes is going to be procured if it can reduce hypoglycemia by 15%. I need to make sure that I can provide evidence that I get to 15%, because if it only reduces it by 10%, it's no longer cost effective. It's really important for my value story. I need to be able to demonstrate unequivocally that I do get to that 15%. And it's really important that you highlight the areas that you're going to come under scrutiny later down the line. Now, obviously, we've been through this. Segmentation is also really important. So again, excuse the picture here of the whale. That wasn't the intention here. The basic argument here was the Ivf argument, and it's that technologies can have a massively differential impact across different groups. It can be exactly the same technology given to slightly different people that have hugely different outcomes. So IVF is a great example. Studies have shown that IVF in women over 42 has a 5% effectiveness, but in women under 40 it's 75%, and in women under 30 it's higher still. So if I was selling IVF, I wouldn't want to take a pooled estimate of my effectiveness. If we take the two, 75 and 5, combine them 80 divided by 2, 40%. I wouldn't want to say that my effectiveness is 40% by including the women over 42. I'd rather exclude those women over 42 and say this technology is for women under 40 and it's 75% effective, because then that way the value proposition is far higher. We want to offer these technologies ultimately to where they're going to have the greatest benefit, and the reason for that is because procurement are most likely to get involved with this and to take this on if the uncertainty around this is reduced. And at ORCHA, we've been saying this for years, that the strong advice is to start with a much smaller group, trying to expand outwards once you've been selected as a preferred provider, once you're working with a clinical group, once you're procured and you've built up some trust, you've built up relationships, to then use your clinical teams that you've worked with to expand further throughout organizations, rather than trying to capture everybody at once. And there's a real difficulty there in that if you aim too high, unfortunately, a lot of the time this doesn't work out, and sometimes it's best to start with a much smaller group where the benefits are likely to be far higher, do your studies there and move out from there. And we see this in pharma a lot of the time with expansion of indications, and it's a natural thing to do, but you have to start somewhere. And finally, implementation. So evidence is ultimately only the start. We've seen evidence has a massive impact. There's no question. We did a survey where we found that two studies would be great, but what's more convincing than having two studies is having a healthcare provider recommend your app to another healthcare provider. So that tells you that it's not all about studies. It's about getting healthcare providers on board, and this is really key. You need to be able to get healthcare providers on board with your technologies by involving them earlier and by having them be your champions going forward, because ultimately a mixture of studies and healthcare provider championing is going to be the way that you're going to find the easiest path through procurement. And again, just coming back to the 5 steps, and then we're done here. 5 steps to unlock the value of digital health tech from an economic perspective: making sure you collect and analyze patient level data, making sure you've mapped out the condition, making sure you've mapped out the disease area properly, modeling your technology versus the current competitors, taking account of any uncertainty, and identifying the groups that are most likely to secure reimbursement, those with the greatest benefit. And thank you. I appreciate that was very much a whistle-stop tour, and I'm happy to take any questions either through the hello at ORCHA or now. Thank you very much. Okay, so I'm just looking. Give me a second. I'm still quite new to this. Is this being recorded for later replay? Yes, it is. It will be available later this week. Will the slides be shared? Yes, they will. Question here. Oh, so these have all been answered. Oh, fantastic. Okay, so do we have any other questions that haven't yet been answered? Okay, it's like a wrap.
There's a couple more coming through. Sorry.
Yeah.
So we've got, can we apply this info if we are creating apps for healthcare professionals? Then absolutely.
Yeah. So
do ORCHA help with the DTAC So yes, ORCHA can. As you know, ORCHA is standard review apps against the ORCHA baseline review. We are now looking at incorporating the 30% of the DTAC that isn't already included into the OBR. So we will be supporting reviews against the OBR going forward. Simon, outstanding presentation, couldn't agree more. Do we need to get DTAC approved? That will depend on the area that you're in and who you're trying to be commissioned by. In a lot of instances, they may be looking for evidence of a DTAC review, or in our instance, we get a lot of reviewers, a lot of developers coming to us saying that regional commissioners, healthcare providers have asked for evidence of an ORCHA baseline review and a standard one that scores over 65%. So that's what we are asked at the moment. So that will depend on the region and the commissioners that you're speaking to. Where do I get data on video consultation usage? That's definitely one for you, Simon.
That's fine. So just to be clear about the question, if you're looking to develop a model, for example, that says this is the proportion of patients who, when offered, would use a video consultation. So, all of the various primary care consultations that we've had, PubMed will be a place to start to literally do a very top-line literature review to find, okay, what has been recommended here. The issue is that obviously there are thousands of different video consultation options. People use Skype, people use Zoom, people use dedicated platforms, kiosks. It can be difficult to get hold of this information. So the recommendation would be to do a literature review to pull in all of that. If not, if you can't get hold of it that way and it's truly an evidence gap, I would recommend speaking to a series of healthcare providers, potentially primary care, and to ask them from personal experience how often they recommend it, how often they use it. You could also put this out to the community, to through social media, and ask real world patients whether they've used it and do it that way. As long as you can provide some evidence and show that you've made a really concerted effort to fill this evidence gap, then that's acceptable. If you're providing a video consultation, then it might be worth you speaking to the clinicians that you're working with. But yeah, there's so many different ways. But if there is a more specific question than that, and if I've completely missed the point here, then obviously email me at hello@ORCHA, and I'll happily provide a much more detailed response.
Brilliant, thanks Simon. So there's a couple in here around the DTAC. So worth saying that there will be an upcoming webinar specifically related to the DTAC and the various processes for how you can get involved in that and how ORCHA can support that process. I'm just looking down the list, Simon. I don't know if there's any particular questions that you want to pick up now on the rest of this. We've got 6 minutes left.
There's one by Charlie Taylor. Does ORCHA assist with the data collection process as opposed to just reviewing the data? ORCHA will assist with recommending which outcomes you should be collecting, if you which outcomes are going to be looked upon the kindest by procurement, and ultimately which ones are of value. We also obviously have our data security teams and specialists in here that can advise on the relevant criteria that you would need to meet from a data, ultimately from a data governance perspective, and we can help with that. In terms of actually collecting real world data and actually getting this data from patients, if it's from apps, obviously this is down to you and down to collecting this from your users. If you're looking for secondary data and you're looking to generate data in the real world, we can help with that. We can help set up studies for you so that you can generate this technology, generate data for these technologies. We're working in the southwest of England now with some pretty big organisations down there to set up these real world implementation studies. So if you're at the point where you're past proof of concept and you have a working technology, we can talk about helping to get that into the hands of patients that need it.
Very good. What about just a couple more just coming through around the DTAC. Depending on which apps will require DTAC will depend on the system, will depend on the organisation that you're talking to. So there will be, as I say, far more information coming through about the DTAC going forward. What about Ian's question, Simon? So shortly launching at 6 NHS sites. enable greater efficiency in provision of care to patients and their families. How would you structure the evidence base for this? It seems addressing NICE guidelines and NIHR unmet needs doesn't count. Why is this?
It's a really good point, Ian, and obviously it should count, but and ultimately it comes down to the area. As we know with the NHS, it's a strange beast in that you don't just get approved once; you have to be approved by every individual business, unfortunately. For me to answer that with certainty, obviously a little bit more information about precisely what the technology does would be useful. From the information you've provided there, if it's purely about efficiency, it would technically be a tier 1 app. If it's providing care or it's providing information to patients and families for a very specific condition, more likely going to be tier 2. So generally, evidence for this type of app would be getting a relevant healthcare provider on board that says that the care that you're providing and that ultimately what you're doing is A, worthwhile doing, and B, that it meets or improves upon existing guidance and methods, so that ultimately you need someone to be able to put their name to it to say, yes, I would stand by this. This is doing a lot of good for patients. If it does anything more than that and it starts, calculating or diagnosing or preventing or treating, you would unfortunately need harder evidence. So, observational data, for example, that looked at outcomes pre and post. I can catch up with you separately if you want to email me, though, if you have more specific questions.
Brilliant, thanks, Simon. I think there's just 2 minutes left. I think there's just the one from Laura. So she asked about do apps and digital health interventions need CE marking? So just a couple of sentences on that.
No, that's fine. So obviously you can self-certify, and ultimately again it depends on what your technology is doing. A lot of these answers are contingent upon what the app does. If you're aiming to diagnose, to calculate, to estimate, to treat, unequivocally you're going to need to get a CE mark, because otherwise you could potentially be flagged as an illegal medical device if you don't have the CE mark. If you're doing something that does require that kind of mark and you've not got it, you can be flagged as an illegal medical device. And obviously from even just from an advertising and a PR standpoint, you don't want that. You want to be able to go through the process, and obviously it is quite an unwieldy process. We appreciate that, and ORCHA do provide help in getting through that. We've got Adam and we've got Matt, who are far better at answering questions about CE marking than I am, and they'd be able to help you through it. But it could just be that you just need to self-certify for the minute without knowing precisely what the app does. It's hard to answer with absolute certainty, unfortunately.
Very good. With 1 minute left, I think that's every question answered.
I think Marie has just asked about NHS procurement. We can provide help with NHS procurement. I'd say our CEO Liz is probably the master route finder through NHS procurement. I think if anyone did want any advice or a bit of help or consultancy, I'm sure she'd be able to help. But we do provide a separate work stream on procurement, so it could be that if you just get in contact separately, we can provide you with a bit of materials and a similar slide deck that we provide on procurement that may help you.
Fantastic, thanks, Simon.
Okay, I think there's one more question there. Can you expand on which type of apps require DTAC? The obvious answer, and the clear answer is it's currently uncertain and need to know more about the app, but obviously ORCHA do cover most of the DTAC anyway, and we'll soon cover all of it, so it will be by definition done if you went through ORCHA. Brilliant. Well, thank you very much, everybody. It's been a pleasure. And again, if you have any questions, please email hello@ORCHA, and we will happily get back to you as quickly as possible to answer any questions that we've failed to do so far. Okay, I'm going to close this now. So thank you very much.